Hi, welcome to today's EQIP webinar. We're so glad you joined us. As we always do, we start with some announcements. The announcement this morning is that we had scheduled a webinar for July, the last Tuesday in July, on employee health. We're going to postpone that one. We don't have a date right now for you, but what we're finding is that the summertime is very difficult to get, well, speakers confirmed for one, but also our attendance seems to be lower in the summer. So at this point, we're going to give you guys a break, and we'll be in touch soon about when we reconvene. So just wanted to let you know, and we'll send out an email about that, canceling the July webinar for the EQIP next webinar. So today we're very pleased to welcome Sara Podczervinski. She is the relatively new HAI Program Manager with the Washington State Hospital Association. Many of you are familiar with Sara. She presented at our first annual EQIP conference in Spokane in 2015, and she's been a speaker for this EQIP program previously when she talked about surveillance techniques. So we're very pleased to have her back, and today she's going to be talking about communicable diseases, bioterrorism, emerging infections, all those things that as infection preventionists we need to be aware of. So with that, I'm going to turn this over to Sara.
All right, thank you, Jamie. And so I hope folks can hear me, and Jamie is going to let me know if there's any audio issues. But I'm happy to be here today. And especially grateful for folks for calling in on a sunny day in the middle of summer. So I have to say, just to start, this is a really big topic. To cover communicable diseases, bioterrorism, emerging infections is ginormous. So I don't intend to cover every little detail today. I kind of see this presentation as more of a primer, a conversation starter. And some things to think about. So I plan on telling some stories and diving into detail on a few things, but I don't really want you to leave this webinar with your head spinning. All right, so I am going to. All right, so I put together a few learning objectives for today's talk. And as I mentioned, this talk is going to kind of run the gamut of communicable diseases through bioterrorism. And really, you know, I'd like you to walk away with an understanding of some of the definitional elements for emerging pathogens, bioterrorism, and learning a little bit more about public health's role in communicable disease surveillance. All right, so I thought I would start with kind of the easier stuff. So let's looking at more of the everyday bugs that we tend to see, and then escalate through the talk and kind of move up to the more rare events. So bioterrorism, emerging pathogens. All right, so to start off with, I wanted to do a really quick review of communicable diseases. Now, you are all familiar with our beloved NHSN reporting for central line associated bloodstream infections, C. diff, surgical site infections. But for today, I'm actually going to be talking more about notifiable condition reporting. So things like salmonella, campylobacter, hepatitis, and those communicable diseases are all kind of contained in a list known as notifiable conditions. And those notifiable conditions are not limited to just infectious diseases. There are other conditions in there that are not infectious in nature. So those lists are reportable, and they're reportable to 35 local health jurisdictions across the state. And you guys are all probably very familiar with your particular local health jurisdiction. I can tell you that over the last couple of years, the local health jurisdictions in Washington state and across the country have become more involved in healthcare-associated infections. So they're becoming more of a resource, which is really exciting, whereas previously local public health, state public health, we were a little bit more limited to dealing with infections that happen in more of a community setting. So I would advise you to get to know your local health folks and look at them as a resource, and feel free to call upon them. All right, so just a little bit of history about the national reporting system. It's been in place for a long time, so for over 100 years. And when it was initially developed, to track death, which is a pretty morbid thought. But luckily, as I just mentioned, that is evolving. So we're not just tracking infections. We're also, public health is here to collaborate with you in the hospital to assist in investigations and provide some resources to help with prevention of infections. All right, so I like to tell stories because I feel like we all really benefit from hearing about real-life events. So let's take a healthy one-year-old. So this is a 13-month-old little girl. So she's a daycare baby. She is a feisty little girl, and it's March. And so this is springtime. Flu season has already passed. But she's got a runny nose. You know, she's around kids all day, and she's not feeling good. She spikes a temp, and that temp spikes really fast. In fact, so fast that her body can't handle it, and her body starts to seize, and she goes into a febrile seizure for 10 minutes. Very scary. Ambulance is called. She's rushed to the hospital, and she actually has a temp of, believe it or not, 106.2. She's got upper respiratory symptoms. Luckily, no pneumonia, no urinary tract infection, but obviously she has to be admitted. She does have another seizure through the course of her illness, and eventually the docs are able to get her fever under control. She's diagnosed with adenovirus. This is a hardy virus that we usually see spikes of in the springtime and the fall. So right kind of outside the time of flu season. So my question to you all, and I realize that since this is a webinar, I'm just kind of talking to myself in a room and you can't answer, but feel free to talk to yourself wherever you are, because I'm going to ask a couple questions. Because in this situation, so the patient, she does fine. She's discharged home. She's doing really well. Her illness resolves. But you come into work and you're reviewing your micro reports, and you notice that there's 4 new cases, and they all happen to be on the same unit. This is not what you want to come to work and see. Should you report anything to public health? You know, and your options are, no, adenovirus isn't reportable. Or in fact, it is reportable. So report the first case and report the outbreak. Or your last option, adenovirus is not reportable, but outbreaks are, so definitely report the outbreak. Now that you guys all have your answers in your heads, the correct answer is the last one. So adenovirus isn't a reportable, notifiable condition, but outbreaks definitely are. So we would advise that you would report the outbreak to your local health jurisdiction. A great resource, if you guys, I'm sure most of you have already seen this, but all the local health jurisdictions have notifiable condition signs, and we also have signs here at the Department of Health. So these are free to download and a great reference to actually put in the back of your public health reporting policy that you have at your critical access hospital. As you can see, there's probably 60+ notifiable conditions in Washington State. A lot of great information is tracked every day. I highlighted the areas of the sign that pertain mostly to healthcare facilities. And as you can see, it's not a ton of infections, but definitely outbreaks are reportable. Any emerging infection that has outbreak potential, influenza-associated deaths that are lab confirmed are reportable, and other rare diseases of public health significance. So this is kind of our catch-all category, and in this category, things like carbapenemase-resistant Enterobacteriaceae would be, or CRE, would be something that we like to know about at the Department of Health. All right, and moving on, and this schematic, courtesy of Dr. DeAngeli from the Department of Health, just kind of shows all the different elements of notifiable conditions reporting. So basically, starting off with providers and labs and hospital IPs, the main thing to take out of this is that reporting to your local health jurisdiction is key. From then on, it's then reported to us, the Department of Health, and then further on to CDC, not usually to World Health Organization, but the gist of this is we're all talking so that we all kind of understand what the trends are in the community. All right, a great resource, and if you guys haven't seen this, it's free to download. Every year, the Washington State Department of Health puts out a communicable disease report, and it's interesting because you get to see what the case counts for certain infections are in different counties across the state, and then it also describes a few interesting outbreaks. So if you haven't seen it, just feel free to take a look. We've got communicable disease reports, I think, for the last 5 or 6 years posted on the Washington State Department of Health website. All right, and just to give you a snapshot of who we are, the Healthcare Associated Infections Program, where we do the tracking for notifiable conditions and CLABSIs, SSIs, all that fun stuff. And this is our team, and we have a really great team here in Shoreline, Washington. All right, so now moving on. So we've kind of talked about the day-to-day infections and notifiable condition reporting, but how do you prepare for the unknown? It can kind of seem scary, and this takes me back to one of the first slides I showed you. This is the not-so-everyday infections. But what I can tell you is if you're preparing for an unknown infection, the biggest and strongest thing that you can have in place, and we learned this in the Ebola situation, is to have a strong infection prevention base or foundation, because that can really prepare you for almost anything. In terms of emerging pathogens, there's 3 elements pretty much to the definition of an emerging pathogen. It has to be new to a population, new to a geographical region, and increasing rapidly. So these pathogens, these emerging pathogens, can be newly emerging, meaning that the infection is new to humans. So maybe it started off in monkeys and was confined to monkeys for a long time, but something happened, and now they're seeing that infection in humans as well. Or it can be a re-emerging pathogen. And in these re-emerging pathogens, it's something that maybe occurred in the past, but for whatever reason, now you're seeing increasing numbers in a new area. So an obvious example to this would be Ebola. I mean, for years, since 1976, there's been clusters of Ebola outbreaks that have been confined mostly to smaller community settings in Africa. But what happened in 2014 was a situation where you were seeing more urbanization, and the virus kind of leapt from a smaller village setting to an urban environment and created chaos. So there are these kind of social factors that can really affect the emergence of these types of pathogens. So, and it's not just social factors like war or urbanization, but can be microbial. Think about antimicrobial resistance and other things like environmental, floods, earthquakes. All right, so in terms of emerging infections, there's a huge spectrum of the different types of diseases that are considered to be emerging. The photo you're looking at on the screen is Marburg virus, which is a hemorrhagic causing virus, and this is actually, the World Health Organization recently identified this as one of the most dangerous emerging infections there is, and it's considered to be extremely dangerous, as a matter of fact. But just bear in mind that the other things out there, like HIV was once considered to be an emerging infection. MRSA was once considered to be an emerging infection. So these are things where we see a lot of change. It's very dynamic. This is not a stable area because these bugs change all the time. And the scale of these emerging pathogens can really vary. I mean, some of these can be like an emerging type of E. coli where you have a cluster of 20 cases compared to something more catastrophic like the 2009 H1N1 situation where there were nearly 600,000 deaths. All right, so in December of 2015, the World Health Organization put together a group of experts, and these experts were from the virology world, microbiology, immunology, public health, mathematical modeling. A lot of really smart folks sat in a room for 2 days, and they took these nine ranking or these 9 elements that you're looking at on the screen, and they ranked infections to determine which ones were the most concerning emerging pathogens for 2015, 2016. So they looked at things like how deadly is the infection? How easy is it to transmit? Is there a vaccine for it? Is there an antibiotic or any sort of treatment for it? How would this infection affect society? So a lot of different factors, and based on that ranking, they came up with a list of infections. So what you're looking at now is the most of the outcome of that workshop and that prioritization work that they did in 2015. And bear in mind, looking at the date, this was in the middle of the Ebola situation, so they were well aware of the Ebola situation and took that in consideration. But there's actually one infection on here that was never included or prioritized. I'll let you kind of think about that yourself and figure out which one you think shouldn't be on the list. It's actually influenza. And the main reason that influenza wasn't added to this high priority list of emerging pathogens was because, for a few reasons. There's a lot of control measures that people are well versed in, and there's also vaccine for many types of strains of flu, and there's antivirals available. But the other infections, the other 6 infections were still included on that list. All right, so now that we have this base knowledge of what the World Health Organization was thinking in terms of emerging pathogens, we're not just preparing for the unknown, but we kind of have a best guess. We have a best guess of what sort of infections are worrisome out there in terms of emerging infections. So what I thought I would do is just I don't have time to dive into all of these, but I wanted to talk about one in a little bit more detail because it was interesting, and honestly, I didn't really know much about it. So I thought we could talk about the Nipah virus. And if any of you guys have seen the movie Contagion, the virus depicted in that movie, that horrific movie that Gwyneth Paltrow was in, I think Jude Law was in it, was actually based on the Nipah virus. So it's a virus, and I'm not going to even attempt to pronounce the name of the family that it comes from, but it was initially isolated in 1999, where they saw an outbreak of encephalitis, respiratory illness in Malaysia and Singapore. There were 300 plus cases, 100 deaths reported. The incubation is 5 to 14 days. Symptoms range from fever and then kind of get worse from there. I mean, patients were going into a coma within 24 to 48 hours after that initial fever. So could be really devastating. And looking at that mortality rate of 40%, very, very high, with really no treatment, being that it was limited to supportive care. All right. Okay, so most of these emerging pathogens come from an animal source, so they're mostly zoonotic. So for this particular virus, there was a definite animal source. And what they were seeing was that, actually going to go to the next slide here, but it wasn't monkeys, it wasn't mosquitoes, but what's interesting is that initially they thought that mosquitoes were spreading this virus around because they were seeing these weird cases of a febrile encephalitis in pig farmers, but they didn't link the pigs initially because what was happening was they were exporting pigs from different districts in Malaysia, and more of these farms, humans were developing symptoms and getting really sick. So they were thinking, because it was in all these different areas of Malaysia, it wasn't just confined to one space, they assumed it was related to mosquitoes and actually first thought it was Japanese encephalitis, which is spread by mosquitoes. But when they dug further, they actually found that it was related to pigs and to two different types of bats, and one of them is a flying fox bat. Oops, sorry. I'm trying to advance the screen here. There we go. And, you know, as an epidemiologist and an infection preventionist, I'm a huge fan of maps. And this map really gives you a good sense of how the disease could kind of persist and spread in the area. And it shows you two different viruses, the Nipah virus and the Hendra virus. And the Hendra virus is also something that's linked to the flying fox bats. And Pteropus is the fancy name for a flying fox bat, and it shows you their flying route, and then it also shows you the areas where the infections were. All right, so there's a lot of information on this slide, but I think what I want you to take away from this is the fact that with emerging pathogens, if you know the basics, I always like to put things into tables and to break it down. So if you know the transmission, you know what to focus on in your hospital. You know that looking at the list that the majority of these emerging diseases are spread by contact. And you also have the emerging coronavirus like Middle East respiratory syndrome, severe, and SARS. So you really need to focus on your airborne precautions and be aware. How are your negative air pressure rooms? Do you have negative air pressure rooms? Do you have PAPRs? Are folks fit tested for N95s? So these are things that we can prepare for, and even if we're not going to be seeing these really kind of exotic infections possibly ever, and hopefully not ever, this is basic infection prevention knowledge that you need to have for taking care of patients that have measles or tuberculosis. And also, the other piece that's key to look at is the type of illness, right? So you can see that 5 out of the 6 infections report either flu-like illness or respiratory illness. So these are things to flag and to look for when you are and having a strong triage system in place so that when folks enter your hospital system, whichever way they enter your hospital system, this sort of information is documented. And if they do have any sort of flu-like illness, that's caught right away, and those patients are put into isolation. So I thought I found this map, and I just thought it was so cool because emerging pathogens are a big deal, and with all of the traveling that folks do, it's probably going to become a bigger deal. Just think of, I'm sure many of you on the phone have been on a plane in the last month. I know I was on a plane last week, and I'm going to be on a plane next week too. So, I mean, we all travel a lot. And this is actually an older map. This is from 2009, and it shows the map of scheduled airline traffic around the world. And in this particular map, it depicts 55,000 routes. So that's huge. And just something to bear in mind when we're thinking about preparing for these sorts of infections. So the CDC has a great resource, and they publish travel notices. So, this is just a screenshot from their website. But anytime there is something happening in another country, they'll post a travel notice so that folks are aware that, there could be a chance that folks traveling from that region have a higher risk of a certain infection. And the CDC also provides what sort of precautions should be put into place. So I highly advise this is a great resource. Take advantage of it. All right, sorry, I'm just getting a sip of water. I don't usually talk for a full hour, so you'll have to bear with me. All right, so in terms of your facility, with any sort of infection, and when preparing for anything from VRE to something exotic like Ebola, you really need to look at your entry points. So patients checking in, patients coming via ambulance, patients being admitted. And the other piece, you know, with electronic medical records being so prevalent, and that's great, we also need to be aware that we need to get into the practice of making sure that any sort of information that could indicate that the patient could have an infection should be entered promptly into that medical record, and it should be visible in the medical record. And I understand, having worked as an IP, I understand that you may not have a lot of leverage as to where that information goes, but really be a strong advocate and let your IT folks know that having something that is obvious in your medical record showing that a patient could have an infection is a priority. All right, so early recognition in terms of screening for travel can have, you know, huge implications, because there's been studies that have shown that the sooner an infection is identified, the higher the chance of decreasing morbidity and mortality. So this is quite impactful. Really kind of nipping it in the bud from the get-go is key. You know, imagine missing that one case. And we saw this kind of with Mr. Duncan in Dallas. And, you know, it's really important that a screening policy is in place. And there's benefits to this. You know, I know that it's hard sometimes to motivate staff to keep up screening patients for travel, but it really does foster a culture of safety. And what I like about it is that it gives everyone ownership in infection prevention, and it helps practice. How do you communicate about infections? If you're someone that's a receptionist and doesn't usually talk about that sort of thing, screening folks for travel and for cold and flu symptoms and getting that conversation started really does give them that practice to communicate about infections, infection prevention, patient safety. So it's a great tool. All right. In terms of critical access, you know, I feel like I recognize there's challenges because most of the resources out there, as you guys are all aware, are aimed at, are created more for urban-based facilities. My background in infection prevention is in ambulatory care, and I know when I worked in ambulatory care, I always kind of felt like the odd man out because I felt like there weren't really a lot of infection prevention programs that focused on ambulatory care. But what I liked about it was that it gave me a chance to be creative and design my own program and do it my way. So it gave me a little bit more control, and I can envision that as being something, a similar tool that you could use in your critical access facility. And you do have some benefits that some of the bigger hospitals don't have, and that you have likely have a tighter-knit community. And you probably know your community really well, and that gives you a big advantage when you're thinking about things like emerging infections. Really what's key in preparing for these scary infections is being aware of trends and looking at clusters. And policies are important. I can tell you when I was an IP and we had a swine flu hit, we had a robust respiratory virus management policy, and that was a lifesaver. We simply pulled it off the shelf and put it in place, and it was much better to have it at the time rather than have to build it as we go. Doing case scenarios and exercises are great. And it's also fun because you get to work with a lot of different folks. And that's something that I think we as IPs do really well, and it puts us in a great position for dealing with emerging pathogens, communicable diseases, because we can work with public health, we can work with emergency management, with facilities, and just, you know, that's a real skill in just being able to pull all those folks in a room and talk and go through a situation together. Having a solid infection prevention foundation and travel screening is something I feel pretty passionately about, so that's something that I always just include in my talks. All right, so I mentioned policies, and I was on the internet a couple of days ago, and I pulled up University of Texas Medical Branch. They have like 10 plus policies on emerging infectious diseases. And you can download them. They're great. I wouldn't advise that you have 10-plus policies, because actually I had to cut this list off because it was so long. But check it out, because they've got a lot of great things on here. Like if you were seeing a patient and you suspected they had a highly pathogenic, highly infectious disease, how would you do a chest x-ray? Could you do a chest x-ray on that patient? Well, there's Texas actually created a nice policy and protocol on that. So check it out. All right, so now I want to move on to the last topic of my presentation, which is bioterrorism. And just to start off with, after graduate school, my first job in public health was as a bioterrorism epidemiologist. Now, when I was hired, that doesn't mean that I knew anything about bioterrorism. It just means that there was funding in bioterrorism, and I happened to have my degree in public health. So I learned fast, and I still wouldn't call myself an expert at it, but I can tell you that it was a steep learning curve, but like most things in infection prevention, it was really all about collaborating with my partners and helping one another out. So with that said, and in terms of a definition for bioterrorism, there's three main pieces, and that's it's an intentional use of a biological agent to inflict harm or death on a population. So this isn't a new concept, and there's been many examples in history that show that this has been used as a tool to hurt people. There was actually back in the 14th century, cadavers were dropped into the enemy wells during wartime to poison the drinking water and hurt the other army. So this is something that happens, and we all saw what happened with the anthrax attacks. And this was back in 2001. So there were 7 letters that were sent to different buildings. And in total, there were 42 buildings that were affected by these anthrax attacks. 22 cases, 5 deaths. But imagine if one of those 42 buildings had been a hospital. That would have been devastating, because decontaminating for anthrax is really, really challenging. In fact, they did a study that looked at just how much money it costs to do all the decontamination, which took years, by the way. To do all that decontamination, it took $320 million. And that was just for the decontamination of the buildings. So it can be a huge deal, and this was really a wake-up call for all of us. And, after this happened, most of the hospital licensing agencies really started to write in to their hospital requirements that you need to have a bioterrorism preparedness element to your comprehensive emergency management program. So this is something that we're all required to do on public health. And like I said, it doesn't mean I don't consider myself to be an expert in bioterrorism, but I do know epidemiology and infection prevention. And so that's putting that knowledge into a bioterrorism plan is key in working with your emergency management folks. All right, so ABCs of bioterrorism, there's a broad range. So there's bacteria, viruses, toxins, and they can all be implicated in bioterrorism. And the ranking system goes ABC. The worst type of bioterrorism would be category A. So these are those that, if you read that description, it's like the ideal bioterrorism agent. It can be spread easily. So, and if you're thinking about ideal spread, probably if you're trying to hurt a large population of people, aerosolization would probably be your ideal way to disseminate that bug. Ideally, it can be spread from person to person, high death rates, create public panic, and social disruption. If you were to kind of plug in biological pathogens and toxins into each category, it would look like this. And there's actually a full list on the National Institutes of Health website, but you can see there's a lot of agents up here that probably aren't surprising. I mean, smallpox, shortly after the white powder attacks and anthrax, we were all going through the smallpox vaccine clinics, and there was a lot of things happening, and smallpox was the big concern then, along with anthrax. If you look at C, you'll see some infections there that you're probably really familiar with. These are emerging pathogens that we see more often and that could create a lot of chaos and be used as a vehicle for bioterrorism, like tuberculosis, SARS, MERS, antimicrobial resistance. All right. Go to the next. Okay, before I go to this next one, I wanted to talk quickly a little bit about ricin, because this is one where we've actually had a situation in Washington State, a couple of situations, and one in particular was in 2004 when I was working at the Department of Health, when a young man he ordered castor beans from a company in New York, and he ordered a lot of them. He ordered 5 pounds of them, and he ordered so many, in fact, that the company who was selling these notified the FBI and said, look, this person just ordered a lot of castor beans, and we're concerned. And so FBI started to follow this man, and they followed him for 2 years. And what he was doing was trying to turn ricin into a biological agent for terrorism. And he made it through about 50% of the process, and he was doing this in his mother-in-law unit in Kirkland, Washington, and it was at work one day, and I got a call from the Weapons of Mass Destruction coordinator, and he said, look, just so you know, we're going into this guy's house today. This is what's happened, and sure enough, they went in, and they pretty much found a lab that he was building in his house. It was a sad story. He was a mentally ill young man. Luckily, he is now getting the help he needs, but these sorts of situations do happen, and sometimes they can be closer to home than you could ever imagine. All right, so moving on, I wanted to talk a little bit more specifically about bioterrorism readiness and critical access hospitals. And I found this interesting report, and you'll notice the date is a bit old, 2004, but this was someone who did a study looking at hometown hospitals, is what he called the more rural health hospitals, looking at bioterrorism readiness. And in that report, he included a quote which I thought was quite impactful. And this is from President Wayne Myers of the National Rural Health Association, stating, by not taking rural hospitals and populations into consideration, the General Accounting Office is failing to acknowledge the health and safety concerns of more than 65 million Americans who call rural communities home, citing that the majority of the nation's food and water supplies come from rural America, and offers a particular vulnerability to terrorists who aim to threaten U.S. security. So I thought this was, I thought this was great that the article and the references in the article really took into consideration some of the gaps that we were seeing in readiness for bioterrorism, even back in 2004. The article looked at some of the obstacles that they felt that more rural hospitals were affected by compared to urban hospitals. Things like patient transport in areas where there's not easy access to an airport, or it's just more challenging to get to. Transporting a patient or multiple patients in these disaster type situations can be a real challenge. Understanding that there's a bulk of the food and agricultural industry is in these locations, and having safeguards in place to make sure that they are not the aim of a bioterrorism incident. Thinking about surge capacity, this is an issue in most hospitals, but I would say even more so in a critical access hospital. Workforce shortages, fiscal restraints. So there are a lot of challenges, but I don't bring these up to make them the issue seem more daunting, because in this paper they actually did an interesting. They looked at 5 different hospitals all over the country and interviewed them. They talked to administrators, managerial staff, leadership, representatives from law enforcement, and they talked to them about bioterrorism preparedness. What were their obstacles, and how were they getting past the obstacles and moving forward? And a lot of even though the interviews took place in different areas of the country, a lot of the responses were very similar. And there were some really great out-of-the-box thinking that came out of that, and things like thinking about staffing. There were hospitals that were using their maintenance workers to function as security guards, or using school nurses and home health nurses. In terms of surge capacity, making sure that there's agreements in place ahead of time with nursing homes and other entities that could be pulled in during a bioterrorism incident. And also making sure there's uniformity and working closely with regional partners like EMS, fire, law enforcement, and having those plans in place and practicing those plans ahead of time. And then, of course, collaboration, having those strong relationships. All right, so I'm close to the end of my talk, and I appreciate you guys hanging in there with me. As I mentioned at the beginning, this is a primer. I wasn't intending to cover every detail, but I can tell you, if you want to know in more detail how you would respond to an infectious disease disaster like bioterrorism or an emerging infection, check out the APIC text. And this was totally free to download. I just Googled it. So if you Google infectious disease disasters APIC, you can download it. It's like a 26-page document, and it has a lot of great information. Another great APIC state-of-the-art report I found was the role of the infection preventionist in emergency management. And lastly, a plug for the National Ebola Training and Education Center. This is a center that has Ebola in the title, but really they were designed as more of an all-hazard, high-risk pathogen viewpoint. They have Ebola in the title because that is the grant funding that created this awesome education center is linked to Ebola funding. But definitely check it out. They've got exercise materials. They have online education, just a lot of great tools. All right, and so to close, really, I mean, these are kind of scary things to think about if you're looking at emerging pathogens and bioterrorism, but just the knowledge base of infection prevention puts you in a strong position to be successful and ensure that these can be managed. And really, it's about having strong, basic infection prevention, strong culture of safety. And again, as I mentioned previously, having that culture of safety everywhere, in terms of if the patient were to check into a hospital, that receptionist is advocating patients clean their hands with hand gel when they check in, asking about travel, and really giving ownership to everyone. It's everyone's responsibility, and having that system in place will go a long way. Having strong community ties, I know Jamie and through this EQUIP training has talked a lot about doing a risk assessment. So the other thing that can be done is a community assessment. This is something that shouldn't be done alone. I mean, this is something that should be done talking to your city folks, to if you have a tourism board, your emergency management folks, really learning more about your community and whether or not there could be areas where puts you at a higher vulnerability to certain emerging pathogens, bioterrorism, or communicable diseases. What I always like to do is have a go-to resource file. I mean, even if I may never hopefully have to use it, it's always helpful to have all those resources in one location so that I can find it and pull from that. And also keep talking. You know, this is something where I feel like after the Ebola situation, all of us were exhausted, and that's to be expected. I mean, but we really need to keep talking about it because there's always going to be emerging infections. Infections are not stable, and we're going to see them reemerge. We're going to see new antibiotic resistant, and we need to be vigilant. And the last point I want to mention is that in terms of responding to these emerging infections, bioterrorism, and communicable disease, I think we really need to make sure as IPs that we learn a little bit about incident commands, which a lot of you may know about, because that is going to be imperative in this sort of situation. And also knowing that you can draw upon those basic epidemiology, infection prevention skills that you have for day-to-day investigations that you do for MRSA or for influenza. You really, you know, it's about identifying the cause, what's going on, coming up with a case definition, figuring out a timeline, figuring out a risk period, who is at risk, and developing those prevention strategies. So bearing that in mind, I think those basic tools will take you a long way. All right, and I believe that is all I have, and I'm done early. So I'm happy to take questions.
Sarah, hi, it's Jamie. Thank you so much for all that great information. If you have a question for Sarah, please feel free to do the hand icon. Our producer will give you some instructions. You can also chat your question in, and we'll read it out loud to the audience and try to get an answer for you.
Ladies and gentlemen, if you would like to ask an audio question, please click the raise hand icon located on the participant panel to the right side of your screen. If you would like to remove yourself from the queue, click the same icon again to lower your hand. In order to ask a live question, you must have a telephone or microphone icon next to your name. Otherwise, you may enter a question into the chat panel. Please remember to change the drop-down to all participants. Thank you.
And while we're waiting for you to raise your hand and ask your question, we do have something in chat from Martha Jaworski. You probably can read it there. She wants to know, Sarah, do you have any suggestions on communication of syndromic information during times of transition between settings?
Oh, okay. So so the question, I assume, has to do with how do you communicate. So if patient was being moved from one facility to another, is that how you took that question, Jamie?
Right. So I'll read the question again. And Martha, if you're on the line, you're welcome to ask that question. She's on the panel, actually. I think it's more about how, you know, the syndromic information. I think that may be how do you communicate interfacility transfer, that sort of thing, and, you know, maybe what you suspect is going on. I could see how in a critical access hospital where the patient will present and then you are shipping them out to the nearest large facility, you know, what does that communication look like? What kind of information should you make sure you're communicating? Martha, if I'm not communicating that well, chime in.
No, that was exactly what I was getting at, because I think, you know, it's a struggle to get that communication, even if somebody has a known MDRO, a lot of times that gets missed. But I worry about, you know, some of the things you were talking about, like the flu-like symptoms or any, you know, respiratory things that end up, you know, down the road turning out to be something different than what you maybe thought it was. And are you really communicating some of those more subtle things that aren't diagnosed necessarily as MDROs? You know, what's the best? Do you have any thoughts on that? Because I think it can be a struggle, so I didn't know if maybe you had any ideas about the best way to try to incorporate that into your transfer information.
Yeah, I mean, it kind of, I mean, it all depends on, so what, you know, we do have an interfacility transfer communication tool, but that's more geared towards specific pathogens. And in my experience, I feel like, so when patients are transitioning from one area to the next, I feel like it's best to incorporate that information in more of a all-in-one location. So if you have a form that's used in transfers, or if EMT, if there's a form that they provide you, I feel like it would be best, rather than to have a separate form with that information of different syndromes like flu-like symptoms, acute cough, or febrile, those sorts of things. I feel like that would be better served and integrated into documentation that's already used, so that you're not having to hand something separate off. But that said, I feel like a lot of work needs to be done on this. I just attended an epidemiology conference, and interfacility transfer for any sort of potentially infectious patient was a really hot topic. And I think there's a lot more work that we at the Washington State Department of Health need to do on this. One of the things that I'd like to do, I don't have any answers, so I apologize, but one of the things I'd like to do is start communicating more with EMS. So I've touched base with our emergency preparedness folks at Department of Health, and seeking out to hold a meeting with, I'm hoping to include a lot of infection preventionists and EMS folks to get all of us in a room to talk about our challenges with infection prevention and how we can work together a little bit more. So there's that element, and then you also have communicating with other facilities as well, other nursing homes. So this is a big topic, and I apologize for not having answers right now, but it's something
Sarah,
that's very much on my mind.
Martha, thank you so much for the question. While we're waiting for any other questions, I'm going to just pose this to the audience really quickly. As infection preventionists in rural and small hospital settings, what is it on this topic that keeps you up at night, that you worry about, and how can we help you going forward? So think about that. Chat in your answer. Feel free to speak up. You know, I think just having worked in a critical access hospital as an infection preventionist, I know one of the things that always worried me was, you know, I'm immersed all day long in what's happening with the World Health Organization and all the alerts. And so every time we'd have a patient that, you know, happened to travel in from some exotic location or something, and even though they may have just had the flu, I saw all kinds of exotic infectious potential. And so I worried all the time that, am I crying wolf if I say, oh, hold on, he just came from the Middle East and he's got a respiratory illness, could it be MERS? And so I wonder if I'm just alone in that, and that I still want my credibility intact, and I don't want to dismiss something as, it's just the flu when it could be something else. So those are the things I think that many of us worry about. The other thing that I'd like just some advice is, as infection preventionists, are you on your disaster planning committee? If you're not, it might be an important time to explore getting onto that committee. The disaster planning committee is the place where you're going to talk about surge capacity. You're going to talk about staging of that influx of infectious patients. You'll be more aware of the resources that you may or may not have in your community if you're a part of that. So look into disaster planning. I know we're at the top of the hour. Is there any other questions? So Sarah, if you'll advance the slide one more, I believe your contact information will be listed there. I know that when we work with the Washington State Health Department, you all in the HAI program are so easy to work with, and you answer a ton of questions. So I want to encourage all of you to reach out to Sara and her team. They're there for you, especially as you're learning the job, or if you've been in this role for a long time and something odd pops up. I know Sara and her team can help you, but feel free to reach out to her.
Yeah, please do. And if we don't know the answer, we may say we don't know the answer, but we will definitely research it for you.
Right. So before we leave, I do want to make one more quick announcement. As you may or may not have heard, the CMS conditions of participation, they have updated those, and right now they're in the proposal stage. So tomorrow, Qualis Health and the hospital associations in both Washington and Idaho will be offering a webinar to talk about those conditions of participation that are proposed. The reason I'm bringing it up on this call is there are huge implications for requiring comprehensive infection control and antibiotic stewardship programs in critical access hospitals. So hopefully you got the invitation. If not, this afternoon, for those of you on this call, I will send the invitation to that webinar to you again. That'll be tomorrow at 11 a.m. Pacific time, noon Mountain time. Martha and I both will be speaking on that to try to summarize what those changes will look like. But this is really huge, huge for both the PPS hospitals and critical access hospitals. And we're happy to answer any questions you have about those proposed changes. So with that, it's the top of the hour. Thank you all for joining us today. Feel free to reach out to us if you have any questions. Thank you again.